All right, so this one is titled The Transplant as opposed to Getting to Transplant. And here again are objectives that Richard has given me. When is the time to transplant? What's the best regimen now that we have alternate pathway blockers? What should recipients know about transplant drugs and the side effects? And then how is recurrence after transplant defined and why is that important? So the obvious question really is, should patients with C3G be transplanted? And I say that because there was a time, and perhaps it still exists, where some transplant centers would refuse to see a patient with C3G. It's our belief that any patient who's expected to benefit from a kidney transplant should be considered a candidate for kidney transplant, whether or not it is C3G or another disease. And even patients who've had an early transplant failure from C3G should consider a kidney transplant in this day and age because of the advances that we've made in managing the disease and in treating the disease. So risk of recurrent disease with C3G is influenced by sex, by age, by the presence of certain autoantibodies, by what the complement activity is in plasma. And it's important to know that not all recurrent disease leads to premature kidney loss. All transplant kidneys eventually fail, and the key question here is there premature loss of kidney function from something preventable, such as recurrent C3G? And it's important to try and prevent early kidney failure for a number of reasons. One, it's the best way to manage end-stage kidney disease. But the second is that if you have early kidney failure and you don't have access to drugs that can prevent the next recurrence, then you may be facing another kidney transplant with early graft failure. And while in the United States we now have FDA-approved drugs and we hope that everybody has access to those drugs, that may not be the same in many resource-stretched parts of the world. And if you've had a prior kidney transplant and you lose it, you can develop antibodies against other people's tissues, and that can make the next transplant difficult. So you want to try and avoid premature graft loss if you can, because of that problem. So then, when should patients with C3G be transplanted? Ideally, when we believe the disease is inactive, if they're on immunosuppressive drugs, they've been withdrawn, and if urine test shows no red cells in the urine, that typically means the disease is less active. Signs of complement activation should have resolved, such as a normal C3 or an undetectable autoantibody. And there's a variety of assays, as you're familiar with now, that the Moore lab does. Important to remind you that some adults will have a similar process called monoclonal gammopathy, which is a form of a plasma cell tumor, if you will, where antibodies are elaborated by overactive plasma cells that can have properties that can recognize and neutralize complement regulating factors. And those people need to be treated for their monoclonal gammopathy, for their plasma cell disorder, not for their resulting C3G. And how should they be transplanted? As with other transplants, I've just told you a living donor is almost always preferred to a deceased donor transplant. The immunosuppressive drugs we use today for immunosuppression for a kidney transplant has not changed despite the approval of those drugs. So what I'm going to tell you here is our standard armamentarium of drugs. There are two classes of drugs. There is a drug that we use at the time of the operation called the induction drug. It's always an antibody against something. And then we have what we call our maintenance cocktail, what the drugs that a patient who has been transplanted remains on for the life of their transplant. So those induction antibodies, I've shown you the generic name first with the brand name in parenthesis. There's alemtuzumab, there's antithymocyte globulin, or basiliximab. Those are all antibodies against various components of the immune system. And the attempt there is to substantially downregulate, inhibit, or block components of that immune system. And our maintenance drugs, the standard drugs today are tacrolimus, two different forms of it. One is long-acting, one is short-acting. The MMF-MPA stands for mycophenolate mofetil or mycophenolic acid. Either drug can be used interchangeably, and there's essentially two brand names for those two different products. Prednisone still continues to be used. It was our first immunosuppressive drug, first available. when the first patient was transplanted in the 1960s. To this day, we still use it, but not always. There are other drugs that allow us to mix and match to address side effects from drugs or where there's a drug failure, such as cyclosporin, one of our earlier immunosuppressive drugs, azathioprine, an even older immunosuppressive drug, sirolimus, everolimus, and belatacept are drugs that have come out after tacrolimus and give us additional options for managing transplant recipients. As of now, we have no data to support the preemptive preoperative use of eculizumab or the newer complement blockers. And every transplant center who is going to transplant a C3G patient should have a plan for how they're going to monitor for early transplant recurrence. At the very least, they should be looking at the urine frequently for blood and for protein or albumin. Some transplant centers would do what we call protocol biopsies, do a kidney biopsy at specified time intervals, looking for signs of disease. What are the side effects of transplant medication? And again, here I'm not covering the side effects of the complement blocking drugs, just the traditional immunosuppressive medication. So if you're suppressing your immune system, you're going to be susceptible to infections, mostly viral, fungal, and parasitic infections. What is common in the transplant situation is CMV, cytomegalovirus, EBV, that's the virus that causes infectious mononucleosis. Although in the immunosuppressed setting, it doesn't just cause mono, it causes a serious form of lymphoma called post-transplant lymphoproliferative disorder. BKV stands for BK virus. That's a virus that may not, cause serious disease in the individual and doesn't cause death in the individual, but it selectively attacks the transplant kidney and causes kidney failure. Then there are some other fungal infections such as pneumocystis and histoplasmosis. Again, very severe infections that can kill in the immunosuppressed setting and not very common in those that are not immunosuppressed. There are certain cancers that are more prevalent in the immunosuppressed setting, certain types of skin cancers, some lymphomas, and Kaposi sarcoma, a very uncommon sarcoma caused by a human herpes virus that can also typically only seen in some circumstances. There's an increased risk of diabetes, an increased risk of kidney disease. The very drugs we use to prevent rejection and preserve kidney function can affect kidney function. So you have to be very careful in how you use this. Too much can cause kidney damage, too little can cause rejection and kidney damage. Can have GI side effects, that's abdominal side effects, nausea, vomiting, diarrhea. Low blood counts can be an issue. Some drugs can cause hair loss. Some drugs can make you grow hair, sometimes in places that you didn't want it to grow. You can have weight gain. Prednisone is very common, but almost every transplant recipient is susceptible to weight gain in the first 6 months. It's sort of like the freshman 15. Something about a transplant changes how you approach food or how you handle food, and weight gain is very common unless you try and resist it. Also remember, other drugs you take may interact with the drugs that you require for immunosuppression. Certain foods, such as grapefruit juice, can affect tacrolimus levels and can be an issue. Moving on to the next point, which is recurrent C3G after a transplant, I'm going to quickly cover three papers that cover recurrence risk. The first is the oldest paper. This is a paper that looked at all people who had a kidney transplant up to 2007. So this is now a long time ago. 18 years ago, 189,000 patients who had been transplanted in the United States were evaluated. And in that cohort, there were less than 200 patients who had what we then called MPGN type 2, which we after called dense deposit disease, which we today collectively call C3G. 1/10 of 1% of that total cohort had dense deposit disease. The median age for that group was 27, as is typical. It's a disease of younger people. Their median kidney survival, that is the average time that those 179 people had their kidney functioning after a transplant, was about 11 years compared to other people with other glomerular diseases, kidney disease types that are somewhat similar to C3G in the part of the kidney that's affected by disease is about 14 years. So a little less than what you'd expect with other glomerular diseases. The 10-year kidney survival, that is the fraction of people whose kidneys lasted for at least 10 years, was 57.5 for C3G or dense deposit disease, whereas for other glomerular diseases, it was 65 years. And of those people that failed their kidney, about a third or so was from recurrent dense deposit disease. So there is some recurrence risk. There is a slightly lower survival. And you can see that not always is the lack of survival because of recurrent disease. But this is an old study, but it's important to know because we don't have a whole lot of large studies that have looked at these patients. That was a UNOS database, so it was all recipients in the country, and it's sort of a look back. This comes from a single center, so typically smaller number of people, 21 patients. Original diagnosis with an average age of 21 years, 66.7% of them recurred. The median or average time to recurrence was 28 months. That's about 2.5 years or so. And three of those 14 had this MGRS, which was that plasma cell disorder, which should have been treated differently. But at that point, we really weren't even aware that that was an issue. And you can see that kidney failure occurred in 50% of those who had recurrent disease, with a median time to graft failure of about 6.5 years. And the remaining people, 50%, have functioning kidneys. And at the time that the study concluded, just 6 years had passed. And this was now published 11 years ago. So fairly old in terms of where we are with C3G today. So what do we know today? So this is a very recent study. Again, single center, small number of patients, 18 patients. This is a Columbia experience. And so 18 patients transplanted over a 7-year period. Median age at transplant, average age that is 31 years. The median follow-up is just 3 years, so it's a very short follow-up. And 90% of them had recurrence as that center defined it. It was either microscopic evidence of increased cell number in the mesangium or the endothelium, or evidence of C3 deposition, either by that green light fluorescence, immunofluorescence study, or under the electron microscopy. And the median or average time to recurrence was as little as 33 days. Of those 18 patients, 14 of those 18 did not receive anything specific for C3G, meaning they got their blood pressure controlled. If they had protein, they were on a protein-reducing drug, the old style management of C3G. And none of these 18 patients had a doubling or worsening of their kidney function, and none of those 18 patients had failed. At the end of that 3-year study period, the average filtration rate was 53, which is not very far from the average filtration rate for deceased donor kidneys, which is about 58 to 60, 64. And they had a little bit of protein in the urine. It's important to know that in this cohort, every one of them got a protocol biopsy, which is why the recurrence data is so high, because they went looking for C3G in kidney biopsies at periodic intervals. The summary of this particular study is that recurrence is universal or nearly universal, although in this limited follow-up, the impact on long-term kidney function seems to be minimal. This was just published last year. So my summation of these three papers is that recurrence is very common if you define it by C3 deposition under the microscope. This is not very different from another common disease that we have called IgA nephropathy, where recurrence is also nearly universal if you go looking for it. I don't believe that finding C3 in a kidney biopsy means that you have meaningful recurrent disease, meaning you don't have disease that may impact your kidney function. And if you do have clinically meaningful disease, and we can debate what that means, you are likely to lose your kidney function on average in about 5 years. The median kidney survival, the average kidney survival for a deceased donor kidney is about 12 years, whereas for a living donor kidney, it's about 19 years compared to 7 to 15 years for all comers with C3G. So conclusion then, recurrence is universal. Not all recurrence is clinically meaningful. And now that we have new treatments available, perhaps we can drive that down to nearly zero. So how do we do things here? Well, we are willing to consider anyone with a history of C3G. We evaluate for clinical activity. They get extensive testing in Richard's lab. They meet our complementologist, Richard Kala. We try to transplant when the disease is inactive. We monitor for disease after a transplant, and we do not use complement blockers in anticipation of disease, at least not as of yet, but we'll be carefully tracking them. And what do? We don't do protocol biopsies after the transplant. We look for blood, we look for albumin, we look for protein in the urine, and we have a low threshold, a quick trigger for a biopsy if anything is unusual or out of the blue. But we don't biopsy if no disease activity is detectable. And we believe that recurrence is more than C3 deposition. And obviously, if there is clinically meaningful disease, we will consider iptacopan or pegcetacoplan. So summarize, kidney transplant is the preferred option for anybody with C3G. Although risk of recurrent disease is high, it may not occur early or lead to early loss of kidney function. With the new treatments, its place will continue to be refined by ongoing clinical trials. And it's now, I think, more likely than not that transplant centers are going to be willing to accept patients with C3G, whereas previously they would generally flock to transplant centers with expertise in C3G. So it's a good time for people with C3G, regardless of where you live, at least in resource-rich countries where the drugs are available, because you now may not need to travel to a center of expertise unless there's something particularly complicated about your disease. All right, I think I kept to my time this time, and I can take questions if you allow me to. One quick question. Doesn't mean a quick answer, but a quick question. Yes. It's still a long ways off. There are, if you will, very briefly, um, three different ways to get to a kidney that might work for you. There is the truly synthetic kidney, which is essentially a very efficient artificial kidney that you might wear on a belt, where you have your blood flowing through a system that purifies your blood and returns it to you. That is one form of, if you will, a replacement kidney, but that would be a synthetic kidney. The other is xenotransplants, where we have genetically modified pigs to have kidneys that will be available in abundance for people to be transplanted with. The issue there is that you still have an immunologically different kidney that will still need immunosuppression, will still have a limited lifespan. We're a long ways, I think, from getting it to clinically usable age times. The third would be the idea of using stem cells to make your own kidneys. For example, you could take your skin cells, convert it to a stem cell, and grow a kidney. And that kidney then is you. It comes from your cells. It's an ideal situation where you won't need immunosuppression because you see that as part of yourself. You can create potentially any organ. That, I think, would be the ideal state for us to be. But I think all three of those are some ways away. But the latter two feverishly being developed and evaluated. And I think there's plenty of potential for that. Okay, thank you.